Welcome to Do Not Go Quiet.
Here's the deal. I'm the best there is, plain and simple. And nobody can hang with my stuff.
With Eric Wilson.
Just a big, hairy American winning machine.
All right. We're here today with, do I call you Dr. Sean Jacobs? Are you the doctor?
You can. Yeah, you can say that one time and that's about it. From here on out, it's just Sean. Yeah.
All right. So Sean Jacobs is a physical therapist here in Columbia, South Carolina. What company are you with, Sean?
I'm with Ascent Total Performance.
Right. So how is that? Is that any different than a standard physical therapy? Like what's the philosophy from a business standpoint?
Yeah, we so our biggest thing is that we want to show that there's a better way to do physical therapy. And there's several differences. We can go off into the weeds as far as we want to about that, but the overarching thing is that we believe that there's a better way to do things. And kind of the traditional model is you have a physical therapist, some physical therapist assistants, maybe some techs that kind of help people with their exercises and things like that. And I guess I should start off by saying I think that nobody gets into physical therapy for the wrong reasons. I think everybody who gets into the field wants to help people. But the big thing that happens is when you're kind of limited by the medical system and insurance companies and everything like that, and money becomes involved, then the model kind of goes haywire. So what we do is we actually have one-on-one sessions with a doctor of physical therapy for every session. So 60-minute appointments, doctor of physical therapy, one-on-one. That gives us the opportunity to build relationships, and really kind of every session is a reevaluation and a progression. And we don't rely on any other sort of, stacking schedules or handing patients off to techs or anything like that.
Yeah. Tell people a little bit about your background. Cause I did a previous podcast where I, talked a lot about where I've come kind of in the last 5 years on this journey of like multiple back surgeries, going from a guy who was doing triathlons and CrossFit to a guy who had trouble getting out of bed every morning. And there's a bunch of stuff that goes along with that. But just Josh Ortegan, who's a strength coach here in Columbia, is the one that connected me to you. Mm-hmm. And I had been to physical therapists before and kind of normal modalities, sometimes you felt a little bit better, whatever. And when I saw you, it was like the approach was completely different. Mm-hmm. And like where I am now versus where I was 5 months ago when we first started, I never could have even fathomed being here. Mm-hmm. So how did you look at me differently coming in as a patient versus what probably the traditional physical therapist would do?
So on day one, I'm trying to think about where to get started. First of all, I don't take compliments very greatly.
You're gonna have to take them on this one.
I know.
Because I'm in there I'm freaking doing deadlifts in the gym again, and that is a world away from where I thought I would ever be again.
Yeah, man, I can't tell you how much I appreciate it. It's very humbling to hear those kind words, and for someone who's just as passionate about what I do and kind of everything that we can, all the progress that we've made is just. That's why I do it. You know what I mean? It's and we'll get into the details about that here in a little bit. But on day one, I would say that there may not be a big difference between what on the surface level of what I did with you versus what another physical therapist would do. Mm-hmm. There are in school, and the model that we kind of learn through is very, very good at anatomy and physiology, diagnosis and prognosis. We're good at clinical tests and measures in order to figure out kind of what's going on. The thing that I think that I excel at and that our company excels at is really focusing on the human element and talking about not only what's going on, how long have you been in pain, that type of stuff, but hey, where are you coming from a personal standpoint, and what do you want to get back to doing? And my personal brand of physical therapy is always not what is wrong and what can we do. It's how do we achieve your goals? Right. It's because we were in pretty bad shape when we first started. And it's kind of like it would have been easy to say, this is where you're at. This is what we're supposed to do. Here's the textbook answer. But from day one, we decided that there's more to this.
Yeah, I was a train wreck. And you're right. The first time I saw you, I was like pretty pessimistic, not about you, but just in general, because the process had never worked for me before. And, the first thing you asked me was like, hey, what do you want to do? Like, what do you want to get back to? And I'm sitting in my head, I'm like, well, I can now, like, I didn't want to answer the question because
Mhm.
I didn't feel like it was achievable. Right.
Mhm.
And so, but in my head, the thing that had really pushed me back in was, I've coached football for my entire life and I'm not coaching football next year. I don't know if I'm going to coach football again. And I kind of somehow got into this thing with archery, right?
Mhm.
I kind of started getting to this rabbit hole. I watched Cam Haynes. I don't know if you know who he is, but I watched him on YouTube. I saw him do a bunch of stuff. I kind of really got interested in this concept of bow hunting.
Mhm.
And so you're like, what's the carrot? Like hang the carrot out there. I was like, I want to be able to go on a backcountry elk hunt,
Mhm.
and someday. And we kind of had this conversation and we came up with, I think you could do it by the fall of 24. And so that's kind of like literally every day when I train, that's what I'm
Mhm.
thinking about.
Yeah, man, that's awesome. That is there's never been an easier time for us to kind of access real world examples of human motivation and kind of what's possible. And Kim Haynes is a huge influence on me as well. Just like I heard you talk about in a previous podcast, you kind of saw him on Joe Rogan and like, who's this cat? And not only is he a bow hunter, but he's kind of an ultra endurance athlete. And he,
Yeah.
he, he has a really good backstory of overcoming just a lot of self-sabotage and constant drinking and messing things up and everything like that. So it's no matter whether you're interested in archery, bow hunting, running, whatever, it's kind of a heroic tale of just overcoming the challenges. So same situation.
So what, like I said, I was a train wreck when I came in. When you kind of evaluated me, talk a little bit about,
Mhm.
where I was at the time, but
Mhm.
also talk a little bit about why you thought you could get me to a different place than other people had been able to do.
Mhm. Sure. Um, to be completely honest, you're the first person that I ever saw after a disc seal procedure. And you talked about that on a previous podcast where it's a pretty expensive, non-insurance covered procedure for people who have kind of, most other treatments have failed. And they go in and they, inject some substances into the disc to cause them to heal. And theoretically, that's going to help improve pain. You had some relief with that, but after 6 years of chronic compensatory patterns and muscles firing the wrong way and all of this nerve pain and everything like that, it only takes 3 months for the brain to expect there to be pain. And so we call that chronic pain, and eventually it turns into what we call central sensitization. And not to say that's the only thing going on, because it's never just the only thing going on, but we want to take that into account and expect there to be kind of a slow progress at first. Maybe we're going to establish symptom irritability, which means how much.
Can you elaborate a little bit more on the central sensitization
Yeah.
part? Because I do think,
Mhm.
there's two pieces to this. There's the functionality piece, but like you said, the pain piece is
Mhm.
really where it starts.
Mhm.
And then where you end up is this loss of all this functionality because of the way you change everything to try to avoid the pain.
Mhm.
So, for a lot of people, there's so many perceptions about what pain is, how do you treat pain, all that kind of stuff. But can you dig a little bit deeper into the central sensitization so people like really understand what that means and how that works?
Yeah, sure. The pain science behind it is incredibly complex and very. We're still figuring a lot of it out, so it's still pretty new, and there's a lot of really good treatments and approaches coming out. But essentially, the long story short of it is tissues heal, but that doesn't correlate well with pain sometimes. So if you break your arm, that bone will heal within 6 to 8 weeks. You can have pain that lasts 6 to 8 years. You know what I mean? And if you don't, if
And
for
why is that happening?
for a variety of different reasons. A lot of it could be catastrophization if someone is also having a lot of other life stressors. It could be just fear of not being able to get back to doing what you want to do. So in the case of a back injury, backs in my experience are incredibly scary because it's so central to everything that you do. Bending down and picking up a pencil causes shooting pain down your leg. You're immediately catastrophizing, thinking, how am I ever going to get back to doing anything fun or worthwhile ever again? And I'm sure you've experienced that. I've experienced that after injuries.
Oh yeah. I mean, when I first started working with you, I literally couldn't walk past the driveway. Like I would get
Mhm.
down to the end of the driveway and maybe, a block, like we live out in the country, so I don't have blocks, right? But I mean, a quarter mile. And by the time my entire right foot would go numb,
Mhm.
my entire right leg had all this shooting nerve pain. And I would have to like stop just to get back. And
Mhm.
so like for me to be like, oh, I'd like to be able to walk
Mhm.
right, without being miserable, like
Yeah.
that's where it started. So
Mhm.
I was experiencing that exact same thing that you're talking about.
Mm-hmm. So I like to take the approach of we have to look at everything. We have to look at structures. We have to look at tissues. We have to look at nerves. We have to look at movement patterns. There is no just one size fits all approach. We have to look at how the brain is responding to this. How long have you been in pain? Is your body expecting there to be pain with non-threatening movements? You know what I mean? So
Does your body actually start to anticipate, like, does your brain anticipate pain versus the pain actually, like, at a certain point, the pain signal's there, but does your brain actually start to anticipate that pain signal?
Yeah, there are studies that show your brain will actually experience, for the same pressure, more pain, and it will anticipate pain before pain ever comes. So, if somebody were to say that they're going to shock your hand and then press a button, even if there's no shock to the hand, your body could. That's just a kind of a random example, but your body will anticipate there being pain before there's any physical damage, and that's something that is really tricky, and it's a lot of patient problem solving trying to get around that.
Yeah, that makes sense.
Mhm.
So you're working around this whole central sensitization of pain. So once you identify that, what's your next step? What are you doing with people?
This comes from an old interview that I listened to with Adrian Lowe. I say old, it's probably 4 or 5 years old now, but he's one of the leading pain science researchers. It's an entire field looking at how do physical therapists tackle the problem of chronic pain. And we can get into the whole opioid thing here in a little bit.
Yeah,
But
which is interesting because I actually used to work for Purdue Pharma.
oh, gotcha.
So I was an
Yeah.
OxyContin rep in like the early 2000s.
There you go. So I'm sure you know more about that than I do.
Well, I know what we were taught,
Hmm.
right? And what I've learned a lot since then is that we were taught certain things, but things were left out,
Hmm.
right? Which, like you said, we can get down. I don't want to veer off of this path first,
Hmm.
but yeah, it's a whole different rabbit hole. You're right. So go ahead. I didn't mean to interrupt you.
No, you're fine. So when they looked at, I think it was 52 different interventions to figure out what are the top most effective ones for chronic pain, they found general exercise, and I don't think this is any particular order. General exercise, so cardiovascular, whatever physical activity you can do. Sleep hygiene. So not necessarily the amount of sleep, but also we want to eventually get to the amount of sleep, but quality of sleep. Pain science education, which is kind of the thing that we have to do on our part, but also we can do a better job of publishing material that people can learn about pain on their own. So just like we're having this conversation right now, pain science education. And then the fourth one, which I find to be the one that's most kind of abused and overrated, is goal setting. So that comes down to short-term goals. If you can only vacuum one room of the house, we got to learn how to vacuum too. But then also long-term goals. So setting that carrot out there and figuring out what is the light at the end of the tunnel.
Yeah, that was for me, that had a huge impact. Now I've always been a goal oriented person. Like that's always driven me. So, having something that I actually thought I could achieve, especially when I think one of the things you run into so much with these kind of chronic pain situations is the loss. Like people they lose hope.
Mm-hmm.
They literally think, I mean, I was there, right? I literally thought, I'm a guy who's been physically active, competitive athlete my whole life, and I literally thought I'm going to be debilitated, for the next 30 years until I die. Like
Mm-hmm.
and I was struggling a lot mentally with that. Like it impacts so many parts of your life.
Mm-hmm.
And so when the first time I met you, like hour-long evaluation, we got done, and you were like, "We can do this."
Mm-hmm.
You were like, I don't think most of it's your back. You do have some degenerative back stuff, but most of the pain you're experiencing is coming from things that you have done over the last 5 years to compensate for your pain, shortening of muscles, shortening of nerves, all that kind of stuff. And you're like, I think we can alleviate a ton of it and get you a ton
Mm-hmm.
more. So why do you think that? Like, let's just say in my situation,
Mm-hmm.
talk a little bit about what I was like when you evaluated me. And then from your perspective, why did you look at that and go, I think we can fix this when
Mm-hmm.
nobody else could?
I'll pull back the curtain a little bit, get a look into the thought process here.
Yeah.
I'll be honest with you. You were a train wreck, right? Like
Yeah.
everything
I
was
was
really,
freaking mess, man.
yeah, and of course. And so we go through the whole intake process, the whole tests and measures, movement analysis. Everything was lighting you up, right? But there were some movements that were less aggravating than others. Which right off the bat, I'm thinking, perfect. We're going to lean into that. We're going to see if we can chase that down.
But
And
also just for
Mhm.
perspective of people like listening, right? I couldn't stand up straight.
Yeah.
I mean,
Yeah.
like talk a little bit about
yeah.
when you evaluated me, what from an evaluation standpoint, what could I do and what could I not do?
Yeah.
Just because
So
I think it's important for people listening to be like,
Mhm.
have some concrete examples of
Mhm.
how far gone somebody can be and still be where I end up now.
Sure. Yeah. So the way that we look at low back pain, especially pain that's radiating down the legs, is does it respond well to forward bending, backward bending, both or neither, right? And you're permanently kind of bent forward when you're
Sure.
standing up straight.
Yeah.
So sitting down relieved your pain kind of temporarily, which means that okay, perfect. We're going to lean into that. We're going to use that as pain relief. We couldn't even test your extension. So lumbar extension is something that most people with radiating pain tend to eventually respond well to. Not in the case of acute stenosis, or if extension is aggravating your pain, that means we have to find a way to get there, but it's not going to be as direct as just kind of tackling it and hammering it. So what we did was we figured out some ways to just get things moving, because one of my favorite phrases is motion is lotion. There's a high amount of inflammatory chemicals and inflammatory cascade that's
That
going
could be
on around those
used
nerve
in
roots.
an inappropriate manner.
Sure.
So let's not.
I totally get that. So the movement that we're doing is actually going to physically pump that inflammatory chemicals away from those nerves. So we're physically flushing that out. Our body is 70% water. So we are using movement to replenish kind of the healthy tissues and the healthy fluids and the healing factors around those nerve roots. And we just have to find any way to get moving. And that
And
was it.
as much as that makes sense,
Mhm.
it had never been said to me. Like
Mhm.
no one had ever said that to me in
Mhm.
5 or 6 years.
Mhm. And
But it makes perfect sense.
yeah, and that's where I think kind of just my own personal brain, and my wife calls me a dog with a bone about some things, right? And if someone comes to me for help, I'm not gonna give up until we figure out a way. And if I can't figure out a way, that means something serious is going on. So my thought is not what's going on, but how can we achieve those goals? And even if it's at the basic level, if we can figure out any way to get things moving, we can fire some muscles, we can just kind of get a foothold of progress. We just baby step forward, and that's really what it comes down to. So we started lying on your back with some rocking side to side and some kind of glute bridges that were, even the glute bridges were pretty aggravating, but I was like, you know what, we got to do something. And if this is what did I tell you before, if it's tolerable and it's not making things intolerable, like there's going to be some pain involved with this, but there's kind of a self monitoring and self progression that comes along there.
Yeah, I think that was something completely different,
Mm-hmm.
right?
Mm-hmm.
Which and I was like, I'll take pain
Mm-hmm.
if I know it's going to make me better,
Mm-hmm.
right? The idea of just having pain and completely being debilitated was the part that's discouraging. But you're basically said to me like, look, we're going to kind of do something different every time we come in here. I'm going to give you a prescription when you leave for a week. And if you can go home and do it and your pain level doesn't go past 7,
Mm-hmm.
right, then we're okay.
Mm-hmm.
And as long as you can tolerate that, then let's do that. And that was your
Mm-hmm.
approach, right?
Yeah, and for everybody listening, that was my approach specifically with Eric. That's what we agreed on was acceptable amounts of pain. I typically tell people, a 5 is kind of the ceiling, but you were kind of hanging out around a 4 or a 5, right?
Yeah, that was like my baseline.
Yeah, so we have to. Everybody's different, and that's one of the principles that we adhere to. Is I'm not going to just give everybody the same prescription. It's going to be what can this person tolerate and what do they want to tolerate. And you're a hard charger more than most. So the hard work and the dedication you're putting yourself through, that's why you're making all the progress. I'm just here for guidance.
So you keep going in terms of just obviously you saw that first evaluation and you were
Mm-hmm.
like you said I couldn't even like stand up straight.
Mm-hmm.
You can use me as an example, but when you see somebody like that, because I would imagine chronic back pain is like one of the biggest things you see, right?
Mm-hmm.
That's
For
kind of
sure.
so when you say I'm going to tackle that, the biggest thing, one of the things that you did with me that I completely thought would be contradictory was you were like, we're gonna load weight,
Mm-hmm.
right? And we're gonna get like I'm gonna have you doing deadlifts, I'm gonna have you doing some big muscle movements, and
Mm-hmm.
we're gonna push weight
Mm-hmm.
to make those things stronger. And then talk a little bit about that as well as kind of the extension and stretching everything out that you
Mm-hmm.
talked to me about.
Yeah, so I guess tackling chronic pain is one of the chronic low back pain, especially, but chronic pain is one of the primary things that people come in to see us for. And the strength and conditioning aspect is my personal passion. I'm a strength and conditioning coach, and well, by certification, not by trade right now. But
yeah, I don't even think we did that. So why don't you
Mhm.
go through your training, your where you went to school, where
Mhm.
you trained, what your credentials are, and
Sure, yeah.
then we'll rally back to that.
But I kind of fell backwards into physical therapy because I didn't know what I wanted to do coming out of high school, and I, just thought being a doctor sounded like a good way to make a living, and I knew I couldn't sit at a desk all day. So I thought sports medicine doctor. That was the only thing that I had heard of. So I figured, okay, pre-med. Went to James Madison University up in Virginia, and hated the pre-med route. I hated it. It was just absolutely everything was not what I wanted to do. It just, even the introductory courses were like something just didn't sit right.
Mhm.
But I had just never heard of physical therapy. So I eventually found a hallmate of my then girlfriend, now wife's, was, going to class in exercise clothes every day. I was like, "What do you do? That looks like fun." So she told me that there was a degree called exercise science, and I was like, "That's perfect. I don't know what that, like. Let's just do that." So I just up and changed my major. I just went, okay, there's something called physical therapy. It involves exercise science. That sounds great.
Okay.
I became was always an athlete, but not a very good one. So I knew I had to rely on my brain. Um, I
Sounds
started,
familiar. That's
yes,
me.
I started coaching CrossFit at back probably, so it was 2012, and I did it originally just so I didn't have to pay the gym membership. I was just coaching for a free membership, and I was always passionate about helping people, watching thousands and thousands of movements and coaching people and helping people move, and what does normal, fluid, effortless movement look like versus who needs a little bit of help, that type of thing. Exercise progression and regression. And this is all through undergrad and on my transition into physical therapy school. So I say all that because the exercise science part is the part that you learn in undergrad. And then when you get in your doctoral program, then they focus on the X's and O's of physical therapy. And the exercise science part kind of goes by the wayside.
Okay.
So I made it a point to never lose that. And I have a really good memory for things that I'm passionate about. So it was always, how can I incorporate CrossFit, exercise science, and all of kind of the just that type of stuff into physical therapy and what we're doing? Because you wouldn't be satisfied if I waved a magic wand and got you out of pain, but you were still unable to do the things that you wanted to do. Some people are willing to make that trade off, and I don't really think that that's a great way to go about it. So coming back to where you were and why we started working those deadlifts and working those types of things is because your body will there's a disconnect between what it's capable of and what you're asking it to do at first. And when you first have injury, there's a necessary time where you need to back off and kind of dial things down, let things calm down. Sometimes you need to work around it and work through it, but also you may kind of have a little bit of deconditioning in there. And in the acute phase, that's okay and that's understandable. But if we let that go for years and years and years, that's when you used to be able to deadlift, 400 pounds. Now all of a sudden bending over and picking up the cat is your maximum lift. And that's putting you in a bad place for, general life. Because what if instead of the cat, you have to pick up the dog? Then the dog is causing you back pain. You know what I mean?
Yeah.
So we have to get things stronger. We have to work the strength and the mobility. And also it's a tangible progress. I'm sure you've been given a million different exercises in the past that have no progression, no way to track progress. You can do 10 straight leg raises, doesn't matter. Doesn't, like, you don't leave the physical therapy clinic and call your wife and go, "That was awesome. I just did 10 straight leg raises." But if after day one of deadlifting, even if it's 35 pounds, hey, it's 35 pounds this week, it'll be 45 next week, it'll be 50 the week after, that type of thing. We have a way to get back to doing the things that you care about. And that's really the nuts and bolts of it.
Yeah, you are right. Because before, if I get, if I was prescribed specific, oh, do this, do that,
Mhm.
right? The entire concept behind it was maybe it'll alleviate some of your pain.
Mhm.
It didn't have anything to do to improving functionality, getting me back to doing the things that I really wanted to do.
Mhm.
And like you said, there was no progression to it. It wasn't like, oh, that, the next week I noticed, oh, okay, I can do a little bit more, or I can do something different, or
Mhm.
this feels different. So
Mhm.
it is completely different. So from a thought process standpoint, was that a pretty accepted thought process among your physical therapy training in terms of that approach? Because that's not what I experienced with
Mhm.
most of my previous physical therapy experiences.
Yeah, this is going to get me on a whole nother soapbox, but
Good. Jump on
there's
it.
a
Get on. I mean, honestly,
yeah.
the reason that a big part of half the podcast is about stuff I'm interested in.
Mhm.
But I'm interested in this. But this is like the kind of thing that I wish I had had information about
Mhm.
so long ago. But
Sure.
when people get into the situation, they don't know what to do. They end up either at a surgeon's office getting surgery, or they end up at a doctor's office getting prescribed opioid pain medication, or they just get a doctor who says there's nothing I can do. But nobody's like, oh yeah, there's this route to functionality.
Yeah. So the physical therapy that you had in the past, and this comes from kind of there's a continuing education company that provides really up to date, fitness forward education is kind of their slogan. So it's called Institute of Clinical Excellence, PT on ICE. So it's the acronym is ICE. It's kind of easy to remember, but that's our my mentor and friend teaches a lot of their courses, and they're just great people. They believe in this stuff. They promote this message, and basically the physical therapy that you experienced previously was what they call physical therapy 1.0. We did that. We tried
I think
that.
it was physical therapy point
Yeah,
two.
0.5, right around there,
Yeah.
right? The ultrasound machines, the e-stim machines, the ice packs, the hot packs.
Yeah.
We tried that.
People like pulling on your leg and kind of
Yes.
like, oh
Uh-huh.
yeah, you're a little
Yeah.
bit, unbalanced,
Uh-huh.
like that kind of stuff.
Sure. There's a time and a place for that. Unfortunately, it is almost never, and it is very rare. That we tried that, it didn't work, right? We can look around. The general population is declining in overall health status and disability days and just pain in general. We tried that, it didn't work. So what do we need to do? We kind of need to get people on track and tackle those holistic measures of health, exercise, longevity, sleep, the different things that kind of get people excited about not only living longer but health span as well. So how long can you stay healthy, and how long can you stay kind of just actually engaged with all that stuff? That's what we do. We're at Ascent, we're just banging the war drum slowly but surely, just continuing to fight that battle one person at a time. Every single day we are pushing the fitness forward mindset, and it's not for everybody. It really isn't. Some people just want to get out of pain to go back to their normal life, and that is fine. But there's a huge section of people who have been underserved by physicians and prescriptions and waste your time physical therapy. I'm comfortable saying that because our owner is comfortable saying that. You could go somewhere else and they'll waste your time, unfortunately. And like I said at the very beginning, nobody gets into this field for the wrong reasons, but there's a better way to do things, and it really involves being progressive with your strength and flexibility and endurance and all of that stuff.
As a percentage of the industry, what's the percentage of the industry that you think thinks the way you do, treats the way you do, approaches patient care the way you do?
That is a very hard question to answer.
Is it less than 20%?
Oh, I would say
less than 10%.
I was guessing between two. I don't know. I think it's growing so fast. That's what I want to say. It is growing faster every single month, every single year. Every time the company that we promote puts on a course, that's 20 to 30 people who walk away from that being much more empowered clinicians. So I would like to hope that there's a lot of factors that are working against us, and there's a lot of factors that are working for us. The fact that there are podcasts like these and education is so easily available, people can find those things. The things working against us are bigger hospital corporations trying to keep people in-house and maximize profits over people trying to actually get better, because the way that we do things is not the most profitable. There are trade-offs with everything, and if we're going to have one-on-one time with a doctor of physical therapy, I could legally see 2 people in that hour, but I don't. You know what I mean?
Yeah,
So,
that's normally like a 30-minute appointment with somebody else, and you spend an hour with me. Like that's how it goes.
sure. Yeah, we could see 3 people in that appointment. Depending on the way that you stack it and the way that the licenses that you have in the clinic. I worked in that before as a tech before I got into physical therapy school, and it. You know what I mean? People still get better, and there are great clinicians in every field and every model. So it really comes down to the clinician and how progressive they want to be with that type of stuff. So I think the positive answer on that is that it is getting better in a lot of ways.
So just kind of circling back again, me as an example. So we just kind of talked about where I was, right? That was December. So I'm about 4.5, 5 months from there. And now I can stand up completely straight. Right. And then once I got up straight, I had this issue where I couldn't really, like, my hip was completely tilted. That's getting a lot better. But from a functionality standpoint, like last weekend, I went out with a 20-pound pack. I did a 4-mile ruck and during that ruck, I found a 1/4 mile hill that I like humped 4 different times.
Man,
Right.
that is
And I'm
awesome.
pushing, heavy weight on the bench press. I'm deadlifting.
Mhm.
I still have pain. Like, it's not like, oh, I'm completely out of pain.
Mhm.
Right. I mean, I've kind of figured out um, ice. A lot of ice really helps me.
Mhm.
It really brings the pain level down.
Mhm.
So I ice before I train, I ice after I train, and then I usually ice at night. Um, I probably use more non-steroidals than I need to, but that's kind of what I have to do functionally.
Mhm.
But I mean, just 5 months later, like, I never thought I could ever do this in my life. So when you look at where I am now, what has happened? Like, not just how do we get there, because I think we kind of covered that, but what has happened? What's changed with me physically that's allowed that to occur in such a short period of time?
So in technical terms, you would have had a forward trunk lean and a, left trunk shift. And
Hmm.
correcting that left lateral shift is really what kind of always jacks your pain up and sends pain just shooting down the
Man, you
leg.
are not kidding.
Yeah. And
That is the
that,
freaking bastard of a
yeah.
freaking, like, every time my hip would move that way, it would just be like, whoa.
Yeah, and so you need to slowly over time correct that shift, and you and I tried that on day 1, just hammering it, and it was, like, not going anywhere. That's okay, you know what I mean? So we try things, they don't work, we gotta back off and try a different approach.
Yeah.
So correct, you got standing up straight, that's number 1, that's perfect, and now we gotta we're slowly over time kinda working that in, and what I found out was your hip flexor being as I hate to say the word tight because tight muscles are usually just weak muscles in disguise.
Hmm.
They're not structurally shorter. They're just have been guarded and locked up and angry and painful for so long. It's hard to break out of that. So you and I talked. You were like, "Do you think I could ruck?" And I was like, "Man, put a 20 pound bag on your back, and it might actually help take some pressure off." You know what I mean? Like that might help get some cardio going. And yeah, it's okay if you still have pain as long as that pain comes on at higher and higher intensities. That means you're tolerating more and more without pain. So that's kind of the if you just take a step back over and over again and just look at kind of, okay, you're still having 8 out of 10 pain. I need to know, what did you do to cause that 8 out of 10 pain? Was it standing up and walking to the kitchen, or was it going on a 4 mile ruck?
Yeah. And interestingly enough, I don't have 8 out of 10 pain hardly ever anymore. I'd say now
Hmm.
baseline, I'm probably closer to like 2 or 2, and then when I crush it,
Hmm.
which is 10 times more than I would have done before, I might be at like a 6 or a 7. The only thing that really, really jacks me up is if I sit too long. Like,
Hmm.
that aggravates it more than anything. But so anatomically, it wasn't, were we really stretching? Like, were we stretching muscles out, or were we like, what physiologically, what
Hmm.
did we do? Like, what happened? What has happened? And I know it's not done, but what is
Hmm.
happening that is creating the reduction in pain as well as the increase in functionality?
Hmm. Yes and no to all that. We're physically lengthening muscles because they're tight from the nervous system being wound up and on guard for several years. That's kind of how I like to think about it. I don't think about it as stretching something that's physically too short and just lengthening it. What we're trying to do is build functional capacity through range of motion. And that's really what it comes down to. What's going on inside the body is one of the most hotly debated topics, and you can find research that backs up everything. So it's kind of, it's almost a dead end street going down that road as far arguing about,
Trying to figure out the why.
yeah, figure out the structural adaptations. We know certain things, so we know we can improve um, joint flexibility and the physical motions that are occurring at your vertebrae. We know we can do that. But what people are arguing about is, why was there a restriction in the first place? Was it the discs that were no longer pliable? Was it the ligaments that were too stiff and too short? Or was it just your body's, nervous system preventing that movement? There are people that will die on each one of those hills. And I'm one of those people who is willing to bounce back and forth between whatever paradigm helps achieve the goal. And that might not be a satisfying answer for most people. I know it's not, but it's, I can switch back and we can think it's called a biomechanical model that serves its purpose in some situations, but then we also have to think about it from a pain science model for the other things. And there's really just kind of having the flexibility and the open-minded approach to tackle that is really what helps us get good outcomes with every person that we meet.
So, what about and this is, I guess, not everyone listening to this is going to be like me, right?
Mhm.
Some people are going to be kind of like you said, they weren't CrossFit people. They didn't play football. They didn't do triathlons. That's not their thing, right? They're more kind of just functionally living their life.
Mhm.
How do you get those people back to functionality if those people aren't the kind of people that want to go do deadlifts and really, grind in the gym? Like, is there a different approach to them, or what does that look like?
I'd say it's the same approach spoken in a different language. It's just,
Okay.
hey, you're gonna have to pick up a bag of mulch. Okay, you don't want to pick up a bag of mulch? That's fine. What about playing with your grandkids? You know what I mean? What about putting that, cup in the overhead cabinet? What would you like to be able to do that you cannot do right now? And I've had people say, "Nope, I'm good." And I'm like, that is perfect. Here's my card. Like, call me when we can work on something. Like, I'm not here to drag you through any sort of triathlon or powerlifting meet or anything like that. I advocate for, you know, what can I help you with? And I can help you get there. You know what I mean? And there's always something. And I love working with people who are pessimistic. And, I see a lot of just, crabby folks who've been in pain for a long period of time. And it's all about that first session.
Man, that that will make you a crab now.
Oh yeah.
I mean,
Oh yeah.
it can really change your demeanor.
There's a sometimes it takes several sessions to figure out somebody's why, but you had a stellar podcast on your why. You know what I mean? Some people don't know their own why. And it's kind of up to us to help them figure out, okay, you're having this pain. Well, what would you like to get back to doing? Okay, you want to be able to do this. Why do you want to be able to do that? No, really, why? You know what I mean? Like, if you can't stand for a long period of time, is it just the standing, or is it because you want to be able to socialize after church? You know what
Yeah.
I mean? That's the type of thing where it's like, I want to be able to stand for longer. We got to dig down deep for that.
Yeah. So you gotta find
Mhm.
everybody's carrot, like
Mhm.
everybody's why, and then you can kind of create some motivational factor in there.
Mhm.
Let's just talk a little bit about. I'm interested in your viewpoint on opioid pain medication,
Mhm.
where its role is, where it can cause things to go off course,
Mhm.
within the treatment of pain,
Mhm.
and what that looks like in your head.
Mhm. Yeah, I have to be careful not to speak out of turn on anything. So first and foremost, as a physical therapist, medication suggestions, prescriptions, anything like that is outside of my scope of practice. I can have conversations about, the situation that we're in, the current day and age, or how overprescribed they really are, but I cannot tell you whether or not to take medication. I've told you that 1,000 times. I can't even tell
Yeah.
you whether or not to take ibuprofen. Um, but what I can say is that, I don't pretend to know everything about how we got into the opioid epidemic. And I know there's a lot of good documentaries and research out there, and there's a that story's been told, and I feel like people are still figuring that out. I don't think that it really has played a huge role as far as pain relief in general. The thought process was, I think, that you're in pain. This medication blocks the pain. Why not? You know what I mean? 1 + 1 = 2. Unfortunately, our bodies are just not that simple. And there's something called opioid induced hyperalgesia, in which you can be on opioids for long enough that your body will actually start to experience more pain. And I think that's the situation a lot of people are in, is because there is never an exit strategy talked about with your physician. If the average physician's appointment is between 6 and 7 minutes, when in that time is he going to figure out what your backstory is, what your pain tolerance is, what do you want to get back to doing? Here's a prescription. Let's talk about how to get off of that. Like, I just don't understand when the exit strategy really ever gets talked about. And for most people, it doesn't. So that's where the torch has unfortunately just been passed to physical therapists, because there has been a huge crackdown on opioid prescriptions. And you know the repercussion of that is, okay, you're no longer allowed to have your opioids. Well, what's withdrawal like? Because we're about to find out.
Yeah, I
So
can tell you what it's like. Yeah.
yep.
I mean, when I started taking pain medication, it was like you said, it was you know, when my back first started bothering me.
Hmm.
I didn't take it right away, and then it got pretty bad. And so I started taking, I think I was taking 10 milligrams,
Hmm.
5 milligrams twice a day.
Hmm.
Right. And over the course of 2.5 to 3 years, I got to the point where I was 50 to 60 milligrams a day. Um, and it wasn't, it was interesting because I used to work for Purdue Pharma, right? The company that makes OxyContin. whole different story. But what we were taught, this was almost 25 years ago, right? What we were taught was the body does not build a tolerance to opioids, and that as long as you can control the pain, the dose will stay the same. Right. That is, and that the big thing was that you didn't treat people with short acting pain medication because it created spikes in blood levels, which created euphoria and then created this kind of, potential path to addiction. So keep steady state blood levels that don't create euphoria, and you won't have the need to titrate up. So that's what we were taught. That's not what I experienced. And even though you keep going up on the medication, your pain stays about the same, right? So you're suppressing your pain at 5 milligrams, and then it takes 10 milligrams to suppress the same level of pain, and then it takes 15, and then it takes 20. And that's completely the opposite of what everyone was saying 25 years ago.
Yeah, I think I don't know what the current research and literature shows on them, but I would bet a lot of money that it's probably, and that's not what they were talking about 25 years probably didn't end up being the case. You know what I mean?
I would agree with you wholeheartedly. Yeah.
I've seen way too many times people have that exact same story where they're kind of like, oh, now what do I do? Coming off that stuff is not easy. But the good news is that our bodies produce endorphins that are up to 100 times stronger than OxyContin. And I think I'm getting that number right. I heard that somewhere. So, I've just been rolling with it. But the feeling of endorphins when you get a good workout in, and how much exercise can help alleviate your pain when done appropriately.
Oh yeah. I mean, I'm now at the point where, and I'm not a morning guy, right? I'm the guy who usually likes to sleep in. At least that's what I've been like my whole life, other than when I was, you get yerked out of bed for football, you got to be at practice, whatever. But if it was my choice on a Saturday, I was sleeping until, 11 or 12. And I'm literally now getting up in the morning, 5, 6 o'clock, do my Bible study for 30 minutes. I'm in the gym by 6:30. And when I get done, like I'm in a completely different mental state. Now, coming off pain medication was a bitch. I mean, I luckily had a guy who has since died, but was somebody who specialized in the treatment of dependency on pain medication. And he kind of had this little non-opioid cocktail that he used, like kind of that took some of the edge off the anxiety, whatever. And kind of, it took like 4 weeks to wean me off of it. And the first week I couldn't sleep. I was walking around the house because I had restless leg thing. Like my legs just would not stay still. I couldn't lay down and stay still. It was just like, I felt like I was going to jump out of my skin. So I finally got off of them, and I think you'll probably, the science is pretty clear on this, right? When you take an opioid, the way it works is it binds to the mu receptor in your brain, right? And so when you have opioids binding to those receptors, your body stops making the natural chemical that binds to that receptor. So when you go off an opioid, there's a lag time between finishing it and the time that your brain starts to recreate that chemical. And it's, you really feel super sluggish. You can be depressed, and you feel like, oh my God, like I'm going to like feel like hell the rest of my life. And then at a certain point, your brain starts to recreate that chemical. And like you said, the thing that really, really helps is physical activity and creating those endorphins and creating those chemicals in your brain, a healthy way.
My suspicions were right. You do know a lot more about this than I do. As far it all rings a bell as far as kind of the the binding and everything like that. And it's I like to, there's a joke at the clinic, like, I'm just a physical therapist. You know what I mean? Like, I didn't take organic chemistry. I know enough about that stuff to know that it's to know its effects and kind of how it plays out and everything like that. But at the end of the day, withdrawal is withdrawal and tolerance is tolerance. And I do know that it takes about 3 days for your body to experience some sort of, I can't remember if it's tolerance or dependence, but it takes about 3 days for your body to expect that drug to be there. And that's a scary thing.
That's fast.
Yeah. When you're talking about even kids having surgeries and stuff like that, there's a pretty big push to just prescribe Tylenol now. You know what I mean? And it's, I think that's probably head in the right direction.
Yeah, which is a complete tack away from the whole joint commission thing that was going on 25 years ago. And, you know, everybody's got, you believe somebody's pain, like what they say they have, and you treat it. So I know that's kind of outside of, you kind of have to straddle the line on that. So I get it. Does that, so if somebody comes to you and they're on pain medication, is there any difference in the way you treat them? Or is it just pretty much like, you know, you're on it. That's your deal with your doctor. You know, we're still going to approach things functionally the same way.
I think the best thing is to just build an alliance with the person. So when they come in and we have those conversations, I need to know, you know, what the medical history, what the medication history has been, so that I can have a good gauge on what is your pain experience going to be like, and how much is that going to be affected by exercise. If people are really defensive and kind of withdrawn about that stuff, I'm not going to force it.
Right.
I mean, I need to know that. I'm going to say I need to know this stuff from a medical perspective, because, you know, we're doctors of physical therapy. Our goal is to be, you know, true healthcare professionals in that regard, and we're working towards that. But that's besides the point. We are, well, as a profession, we're working towards that and kind of building more direct access for those sorts of things, so that we can have those conversations. It's a long hill to climb, but that's okay. So when someone's coming in with that, I wanted to just know what they're on and what, you know, their situation is and how irritable their pain is. At the end of the day, it's going to guide what we do, but it's, you know, the end result is going to be the same. So I don't have like a concrete answer for it. It doesn't, oh, if they're on this, we change this and we decrease these reps and everything, because everybody's so individual. And it's kind of like, hey, I'm here to talk to you about this stuff. I can tell you exactly what conversations you should be having with your doctor, because those are the conversations that I would be having, you know, that type of thing. So,
Right. That makes sense.
Mm-hmm.
So well, I'd like to kind of end with the aging process, right? So one of the things that really got me interested in doing this podcast was this really big physical journey that I've kind of gone through, and how fast your body can go a different direction when you take your body for granted in your 20s, your 30s. For me, even in my 40s, it was like you feel like you're always going to be that way. Just from a physical standpoint, naturally, what happens to people over time, and what could people be doing proactively in their 40s, 50s, 60s to combat some of the natural things that will slow you down and take away your functionality?
Yeah, that is we could go all day on that topic. That's
That's
become
a different podcast.
Yeah, for sure. No, it is as many podcasts as you want it to be, because I don't think there's anything really more important for, even when you're in your 20s and 30s, you're still looking towards your 40s and 50s, whether you know it or not. And you try to tell a 20-year-old Sean that, not having it. But, you know, so getting into physical therapy, working with athletes and high school, college, barbell fitness, all of that type of stuff was always my passion. And that was kind of why I got into it. And as you become a physical therapist, you get to work with athletes. You also get to work with people of all ages. So from, 6 to 96 are the ages that I think we've seen in the clinic. And that's just kind of a fun number. But we realize that, there's a saying that if you have a body, you are an athlete. And I kind of believe in that. So if you're in your 40s, in your 50s, in your 60s, there are some really, really, really well researched things that we can lean on to look for longevity. What we know is there is a really steady decline. And well, I say steady, but it's a predictable decline. And everybody's decline is going to go differently. You could have a really long and slow, you know, downward trend toward the end of life, or you could stay pretty high up, and then, whatever age something happens, there you go. You know what I mean? Exactly. And that's kind of what we're after that square curve. We want to be doing the things that you could do in your 40s and 50s up until your 80s and 90s, or however long.
Just drop dead, right?
Exactly.
That's what I'm.
That's the goal.
That's what I'm looking for. Full speed, and then just drop dead.
I'm not shy about talking about that. That is exactly, I want to go boom like that. But and so I like to, point people towards other forms of research, because this is a pet interest of mine. I spent hours learning about this stuff. and people like Dr. Andrew Huberman and Dr. Peter Attia.
Yeah, I love those guys.
Yeah,
Yeah, I
Peter
listen to them too.
Peter Attia just put out a new book, and I think that's a great place to start for anybody who's
What's the
interested
name
in
of
it.
it?
It's called Outlive.
Okay.
I just listened to it on Audible. It took me 3 or 4 days because I'm obsessive, and it's about a 13-hour listen or something like that. But it's absolutely amazing, and it's a great summary of all of the literature and all of the research and his approach toward longevity. He's a physician who's really taken up the longevity space, and he's one of the leaders in that field as far as just talking about all those things. You can agree with some of the stuff he says, disagree with it. It doesn't really matter. All of the kind of the nuts and bolts are there. So I've really started, following a lot of what he says and just listening to the research that he puts forward. And I don't pretend to know everything or, have all of the information or anything like that. But, after your, late 30s, early 40s, there is kind of a decline in muscle mass and strength and cardiovascular endurance. So the two things that we can do are get that mountain as high as possible so that the decline is a farther drop, and try to maintain it as high as possible. And that's really kind of what it comes down to.
Yeah, the things that I've seen with older people in my family, like you said, that the decline in muscle mass, I think plays just such a huge role because it reduces their functionality.
Mm-hmm.
It doesn't support their bone structure the way that it used to. That's why you see all these people walking like this. That's what I was doing. And then they get so weak that like one fall,
Mm-hmm.
you break a hip, they can't recover, you get pneumonia. Like I can't tell you how many people I've seen die like that. It was just because they didn't maintain a strong physical
Mm-hmm.
body as they got older.
Mm-hmm. Yeah, it's terrible. And in addition to losing strength, when you lose muscle mass, you also lose, the largest organ in your body, essentially, because muscle is your biggest depository for glucose. And what happens if you have too much sugar in your system and too much glucose floating around is you become hyperinsulinemic, and I develop all of the cluster of symptoms that are associated with metabolic disease, and that has its own things. It puts you at a higher risk
So
of
that's
cancer.
directly correlated to muscle mass because the muscle absorbs so much of the what was it?
The glucose,
The glucose.
the
Okay.
sugar. Yeah, it's one factor of many, and it's by no means an exhaustive list. Like, that's not the only thing you need to focus on, obviously,
But
but
it's a thing.
exactly, yeah. Because if you right after you exercise, your body is just primed to absorb and put all of the sugar that you eat. It puts it to good use rather than storing it in your fat and around your visceral organs and things like that. That's where inflammation starts popping up and everything starts just going off the rails a little bit.
So really the biggest piece of advice you're saying you could give people is stay functional, do things that at the very least will maintain muscle mass. If they're willing to do it, lift weights at least two to couple times a week, right? Ideally 4 times a week, but at least a couple times a week, and then stay active to some kind of degree where they continue to challenge their cardiovascular system. Is that in short?
You got it. Yeah. So the number one predictor of longevity is VO2 max, and that's going to be your maximal energy, your maximal oxygen consumption when you're doing cardiovascular
That's
work.
the number one predictor of longevity.
That's
I
according
did not know that.
according to Peter Attia. Yeah, that's
Really?
That's what the research kind of pans out to be, is when you get to that, because VO2 max is also strongly associated with your perceived exertion of different tasks,
That
such
is
as
true.
going
Yeah.
up and down stairs, walking around the neighborhood, things like that. So if your VO2 max is, barely enough to cover your daily energy expenditure and you're living at maximum capacity, that's not a good way to be. So, muscle mass, strength are kind of the two that go hand in hand. Muscle mass is a little bit easier to measure, but we really need people to be strong in their hands and lower body, being able to grip something, having enough strength to get up off the ground if you do fall, that type of thing. And the more muscle mass you do have, the more metabolically healthy you should be. So you kind of work on both of those things. And we haven't even touched on flexibility or mobility or, the stamina and different stability aspects that really play into that. But there's an endless amount of research and advice out there for you if you're willing to just go learn about it.
Yeah, I think I'll have you back because I'd like to kind of dig into that whole component just for the average person, about anti-aging and all the flexibility component. Those things are all really, really good things to talk about. Man, I'm so glad you came out here today. Like, this was, I just want to say, like, this is personal to me, right? But I appreciate you so much. Like, what you have done for me has changed my life. It's motivated me to do things like this, to try to get this information out. It has put hope back in my life that I can challenge myself, challenge my body, do things that I never thought I was going to be able to do again. And like now I know in the fall of 24, I'm going to have a 30-pound pack on my back and I'm going to be out west and I'm going to be hunting elk. Like I truly believe that, because I'm so much further than I thought I would be. So I can't tell you enough how much what you've done means to me and how appreciative I am for what you do. You're amazing at what you do, man.
I appreciate that, man. Like I said, it's hard for me to take a compliment, but I can't tell you how much I appreciate being out here and getting to have these conversations with you, because this is why I get out of bed in the morning, and it really, gets me fired up hearing about all of the stuff that you're working towards, and we got a long ways to go, and I'm excited to tackle it. I did want to hold you to task on something I heard you in your earlier podcast. You said, "Am I going to be running around the neighborhood?" Probably not. I'm like, come on, man. Like, probably so. Let's be real. Like,
I just did. Like
I
said last week, I did. Those 4 hills I did. I ran them.
There you go.
With a pack on.
See, look at that. I didn't even have to tell you. That's it. That's my mentality, man. The first time I hear somebody say probably not, I'm thinking, why not?
Why not?
Why not?
Yeah,
that's it. I appreciate it, man. Yeah.
So tell people where they can find you, because I think that's really important. Whatever, like best contact information, whether you're on social, all that stuff.
Yeah. So probably the best way is to reach out through our physical therapy company. We're a brick and mortar mom and pop shop located down in Columbia, South Carolina. It's called Ascent Total Performance, ASCENT.
It's worth traveling to. If you're an hour away, make the drive. I literally drive an hour to get to see him.
We're at Ascent Rehab on Instagram, and you can find us just by Googling. It's pretty easy to Google that stuff these days.
Yeah, that's awesome. All right. Dr. Sean Jacobs, thanks for being with us, brother.
Thank you, sir. I appreciate you.
You're still here?
Thanks for listening to the Do Not Go Quietly podcast
It's over.
with Eric Wilson.
Go home. Go.